once a promise by the Labour government that by 2004, nobody seeking care in A&E departments in the English National Health Service should be waiting for more than 4 hours for a decision to admit, transfer, or discharge. Even though there's evidence to suggest that the introduction of a target reduced A&E waiting times and improved patient satisfaction initially, NHS performance against the target has been declining ever since. So there are several potential reasons why NHS performance has been deteriorating, including a rise in the number of people who are unable to access care in the community. So those are the so-called potentially avoidable hospital attendances or avoidable hospital admissions, but also that the patients coming to hospital today are in fact much more clinically complex than those arriving 10 or 20 years ago. We also know from the data and experiences from NHS staff that A&E performance is particularly affected during the winter period, which is likely because of people being sicker and more likely to require a hospital admission during these times, putting pressure on the limited capacity that is available within the NHS. There were about 600,000 so-called trolley waits in 2019. So trolley waits are indicative of substandard care that results from hospitals' insufficient capacity to deal with patient demands. So over the last 30 years, hospital beds have been halved in the NHS, leaving England with one of the lowest bed-to-population ratios across the developed world. So as a consequence of a mismatch between reductions in bed stock on one hand and changes in demand on the other hand, we have seen a significant increase in average bed occupancy rates to over 92% in recent years. So previous research from the late 1990s suggested that any bed occupancy above 90% will adversely impact on the ability to deliver high-quality healthcare. At that time, bed occupancy was somewhere in the low 80%. So hard to imagine that one day bed occupancy might actually exceed 90% and sometimes even get to 100% for certain hospitals on certain days. Together with my co-author, Rosa Joares, we investigated the spillover effects of high bed occupancy rates on A&E performance in England. Our research is also very timely and important because the current government has pledged to invest an additional £20.5 billion until 2023-24, which provides a window of opportunity for hospitals to regain the strength to improve their A&E performance. We obtained daily information on A&E performance, so the proportion of patients missing the 4-hour waiting time target and the number of trolley waits. Compared with previous studies, we were able to use a time-varying denominator for a more accurate estimate of daily bed occupancy rates. We then constructed a panel dataset with information on A&E performance, bed occupancy rates, and other time-varying information such as the number of hospital admissions or number of attendances for every day and every hospital trust in the country to perform our statistical analysis. So the data covered about 72 million patients that attended A&E departments across the study period. The average bed occupancy rate was around 93%, which remained relatively stable over time. About 71 patients are waiting on average longer than 4 hours per day in the average hospital, which saw a significant increase from around 42 patients at the beginning of the study period. So we found that more than 1.6 million patients had been waiting on trolleys from June 2016 to October 2019, with over 9,000 patients waiting longer than 12 hours. Most interestingly, we were able to model the nonlinear relationship between various levels of bed occupancy and A&E performance and saw clear evidence to suggest that hospitals should aim to reduce their bed occupancy rates to below 90%. This is because A&E performance appears unaffected by bed occupancy below this threshold. Based on this finding, we were then able to predict that the NHS would require about 4,000 extra hospital beds based on current demands for its health services. There have been concerns about potentially negative effects of high bed occupancy on hospital performance and patient care, but so far the evidence has often relied on cross-sectional data, bed occupancy data from one particular unit of a hospital, or flawed estimates of bed occupancy data. We were able to fill this gap with our study by examining the spillover effects of bed occupancy on A&E performance, with evidence supporting the government's move to invest in additional infrastructure. Substantial capital investments could reduce bed occupancy to more manageable levels and translate into improved working conditions for staff and enhanced quality of care for patients.